Hello, and welcome to a special edition of Health on the Line. We're recording and releasing this episode the day after the publication of the government's much awaited and anticipated 10-year health plan. We at the Confed have been busy on the airwaves discussing what this means for our health leader members and their staff, producing briefings for them. All that's available on our website, so do check it out, really in detail briefing around that health service plan. We've had a bit of time now to digest the key elements, and of course they've been leaking out over the last 10 days or so. So even if you haven't read every one of the 150 pages, you'll know quite a lot about the big ideas in this plan. The Prime Minister at the launch yesterday, which I attended in East London, said bluntly that it's a case of the NHS needing to reform or die. I think we all know which of those two outcomes we would prefer. So to discuss the 10-year plan, wow, what a great panel I've managed to bring together for this conversation. Less than 24 hours after the publication of the plan. Claire Fuller, GP, Primary Care Medical Director for NHS England. Sam Allen, Chief Executive of North East and North Cumbria ICB, of course, the ICB that Jim Mackey hails from. And Bill Morgan, former number 10 advisor. I asked them what they made of this plan. Claire, Sam, Bill, a very warm welcome. So Claire, let's start with you. It's really hard, I know, but in 2 minutes, give us your upsum of the 10-year plan.
What, 2 minutes? All right, Matthew, I'll do my best. So 10-year plan, at the heart of it is neighbourhood health. And underpinning neighbourhood health is, of course, primary care sustainability. But the other bits that are writ large through the plan are a relentless focus on patient voice and actually making sure that care is organised around patients' need rather than organisation need. You'll see that focus on technology and the way we can use technology in the future to increase clinicians' time to care and to improve things for the public, and actually a real return to quality. So one of the things I'm really excited about and pleased about in the plan is this return to the modern service frameworks and the commitment to starting with cardiovascular disease and with mental health and frailty and dementia. So I think if you wanted real high level themes, and if you wanted the word cloud from it, I think you'd go with neighbourhood, patients, patient voice, technology and quality.
Yeah, really interesting. And that point, which we'll come back to about patient voice, I spoke to somebody who closely involved in the plan a few days ago, and I said, what's the essence of it? And they said personalisation and democratisation, which is really interesting because that's not, I don't think, where we started. Bill, what did you make of it when someone says to you, well, tell me about this 10-year plan? Well, what do you pick out?
I think it did a good job for Labour politically. I think after the week they've had, the government needed to give Labour MPs something to give them a spring in their step. And Labour MPs they want to talk about improving the NHS. And there's a lot of retail ideas in the plan. It's more of a list of ideas than a plan, I'd say. But politically, it gives Labour the space to talk about improving the NHS, which is sort of in their comfort zone and where they want to be.
Really interesting because I spoke to someone from Keir Starmer's entourage, yesterday at the launch, and he said to me, health is our happy place right now. So
yeah, well, exactly. And I saw Wes in the chamber. I was watching his statement. He was just basking in the glow of his colleagues, and after the week they've had and the aggro in the Labour Party, it's sort of exactly what that party needs, really.
Thanks, Bill. We'll come back to a bit of that later as well. Now, Sam, when I'm asked about the 10-year plan, one of the things I say is, ICBs are dead, long live ICBs. ICBs, which a few weeks ago felt like they were being and are under immense pressure in terms of reorganisation. But you read this plan, ICBs are absolutely central to it, aren't they?
Yeah, they are really pivotal. And I recall back in second week in March when the changes were announced to ICBs, my first take, Matthew, was that was an early signal for change for the whole system. And certainly the conversations I was involved in was, look, we're going to need to change and adapt, but everybody's going to need to change and adapt. The thing I really liked about the plan is the scale of ambition, but also the clarity for the case for change and why we need to do this. And I think the foundations of any plan, particularly getting the impetus for change to actually happen, is that absolute clarity on why we need to do this. And I think for me personally, it feels like a real Bevan moment and certainly something we've all got to get our arms around and be part of implementing.
So, Bill, let's take this forward. I mean, obviously, Claire, who's at the centre, very involved in the plan, and Sam, who's key leader out in the service and also has a national role, they've got skin in the game. You're an independent voice on this, so we'll get a bit of a kind of dialogue going on around this. I want to ask you about the kind of implementation challenge here, but just before we get into that, Bill, reading the plan, is there anything in the plan which would have been inconceivable under a Conservative government? I'm not asking you to judge its credibility, but in terms of the kind of politics of it, is there anything there you think, oh, well, this could never have happened if Rishi Sunak was still Prime Minister?
No, in reading the plan, there's some contradictory ideas in it. So I think the challenge in implementation is going to be resolving those conflicts. So, there's a paragraph in the plan about how ICBs are going to become the strategic commissioners and procure services from a range of competing providers. And then there's another paragraph in the plan about how foundation trusts are going to become integrated health organisations and run all local services in the area. Those two visions are totally incompatible in a way. You might end up with different approaches in different areas, and that's the way you sort of ride both horses. They're two philosophical approaches to running the NHS fundamentally. And actually both were sort of tried under the previous Conservative government. So to answer your question, no, there's not really stuff in there which couldn't have appeared at any point in the last 14 years. And as you say, the challenge is implementation.
Well, look, this is going to be fun because I'm going to obviously turn to Sam, because Sam is obviously running an ICB and also a part of the country where I would suspect we will see some acutes leading these integrated health organisations. So, Sam, I suspect that you don't agree with the Bill that these things are completely incompatible.
Yeah, spot on, Matthew. Bill, I don't agree with you. I don't think they're incompatible, and I'll tell you why. Because I think even when you look back at the history of the health service and you look at the size and the scale of the health service, you'll always have some parts that will have the capacity and the capability to go further, and we absolutely shouldn't limit anybody's horizon. So I think fundamentally as a leader, part of my role is to support those parts of the system that can go further faster, because that can only benefit patients and our communities. And I think that's something we're keen to do. But I think also I've got a healthy dose of realism that not everybody will be ready to do that, and therefore it will be a period of time. And I would say over the 10-year cycle, particularly around that ambition to get everybody to foundation trust status in 10 years, where we're going to be working at that, Matthew, and supporting those that need additional support to be able to have the capability to do that. And I think that's part of our role as commissioners, but equally part of our role as commissioners is supporting those that have got that capability to go further faster.
I think there was a certain frisson yesterday at Jim Mackey telling people that the first IHOs would be established next year. You said that this will take a while to work through. Do you think Jim's maybe being a little bit optimistic about our capacity?
No, I don't think so. I think the plan says approved next year for implementation in 2027. I think that's perfectly realistic for a few systems to have aspects of their systems kind of progress to IHO status, where there, as I said, is the capacity and the capability to do that. And I am really confident here in the Northeast and North Cumbria, we absolutely have the capacity and capability in parts of our system to do that. I do think there will be other parts of the system that have had, years of systemic underfunding, structural deficit issues that will take slightly longer to address. It's not that there isn't the capability and the leadership, but we have, as we know, even if we look back when the foundation trust regime was first implemented, there are some parts of the country that would not achieve the kite mark of a foundation trust at the moment. And predominantly that's because of systemic structural underfunding issues. And equally, I've got some parts of those systems in my own system as well. And we need to put as much emphasis on addressing those as supporting those that can go further faster, become integrated health organisations. But I would also say I don't think it's the only way. And I know, Claire, when you come on to talk about integrated neighbourhood health and GPs as the leaders, making sure that we support GPs and other forms of partnerships to deliver for patients, I think we've got to have that flexibility as well.
So I will come to you now, Claire, and I would say that one of the things I'm welcomed about the plan, and which is unusual actually, is the explicit commitment to different models in different places, to a diversity of ways of doing things. And I think many of the mistakes we made in the past is trying to do the same thing in Cornwall as we do in East London or whatever. And, it's interesting that what you're implying, Sam, is that there'll be different architectures, different models of integration, maybe different models of neighbourhood health leadership in different parts of your system, albeit a very large system. Claire, this question of doing things in different ways in different places, it kind of links into, I guess, one of my areas where I can see a way forward, but I do worry still about how clear this is, and that's really around kind of primary leadership, the capacity of primary, maybe working with community, but to step up into the leadership opportunities that are provided in the plan. Tell me about that, and tell me about what you think needs to be done pretty quickly in order to get primary to the table in the way they need to be there to grab these opportunities.
General practice is ready, and I would say general practice is probably more ready than the rest of the family of primary care. But when we talk about primary care as leader, of course we mean across the whole family. But general practice in particular, this isn't the first time we've been talking about this. Again, this is one of those really good examples of when policy is catching up with what's going on out in practice, and the policy is behind the things that are actually going on out there. So I could take you to a number of absolutely brilliant examples of large, at-scale, what started as GP federations have actually evolved into what you can see will be the basis of a multi-neighbourhood provider, and are able to work in partnership with the acute trust, with the community trust, with mental health trust. So I think the other difference that we've got is, although we're saying that there are different models, we're not in the land of 1,000 flowers blooming. I think we're saying there are three. If you do bottom up, you've got three options. You can stay as you are. You can stay, if you are functioning GP practice, that it's all going really well and your outcomes are great and your patient satisfaction is really high and you're happy with how you're working, you carry on and you stick with GMS, because a partnership model where it works is as good as you're going to get anywhere. But in those parts of the country, either where the ambition is that you want to do something different, you could come together as a group of practices, or in, I think, about 10% of PCNs are now single practices across that bit, and actually say, we want to do more, so we'll take on some more of the neighbourhood services. And then again, places like Sheffield, places like York, you've got Nimbus in York, you've got Primary Care Sheffield, where they've already got really good coverage. You can see they will want to take on more, covering that bigger population, working in partnership, but also provide for those areas where the practices don't want to provide more, provide those practices, and also support and provide GMS in those places where we can't get workforce. Well, that's what's so important. And it's to Sam's point that there are areas of the country where this is thriving, where you can absolutely see that people are going to fly and it's going to be brilliant. But there are other places where you still haven't got people to put the lights on. And what we've got to do is make sure that the populations, and it is the classic inverse care law, isn't it? The people that need the care most are actually the people where we haven't got the workforce. And by putting in place the multi-neighbourhood provider, that provider has got to have the expertise and the understanding of how to run general practice, which is not easy. And some of our trusts that have done this over the years, I think, have found just how hard it can be. And actually, you need real general practice expertise in to run general practice. But we've got to be able to make sure we've got a consistent offer out to the whole country. But the vehicle may look slightly different, but it's definitely not 1,000 flowers.
Thanks for that, Claire. I mean, but Bill, I mean, because of the role that you've played as an advisor, that it is an achievement to say to ministers, to say to the Prime Minister, look, it's not going to be the same everywhere, because politicians, the centre, tend to want uniformity. But what do you see as being the kind of challenges as we go forward about this explicit commitment to allowing different models to exist? That the public will have to, people live in one place. They don't necessarily need to know about the fact the system's different down the road. But what do you see as the political and governance challenges of having an NHS where different kinds of institutions are in control in different places, different models work in different places?
I think it's manageable politically, so long as, frankly, politicians just want simplicity. So as long as they can tell a story of NHS improvement, they'll be happy. The big risk for me is in legislating, because it's fine to fudge under the existing legislative framework, say, and to say, oh, this will be an IHO here and this will be a ICB-led system here and we'll have these different models of primary care. As soon as you try and write that down in legislation, the Parliamentary Council will ask you who arranges healthcare services. Is it an IHO or is it an ICB? And if it's both, and you need to transition from an ICB to an IHO, what's the switch in legislation and what are the transitional provisions? And that's what imposes uniformity, and it's that legislative process. So if I was in number 10 now, I'd be thinking, let's just push that legislative process back. We don't need to go there yet. Let's just let the systems do their own thing and then work out how we do legislation later.
Which is Which,
But that's the
which
risk.
is, of course, what you did with ICBs. I mean, you basically set
Yeah.
them up and then legislation for them having set them up.
Yeah, and of course, the 2022 Act constrained some of the things, the way that ICBs were working, because it kicked local authorities off ICBs. Because again, you have to write it down. There are risks as soon as you write it down, and this is why I try and steer away from it.
It's a really powerful point. Sam, turning to the kind of, again, this kind of the permissive nature of this plan, I mean, let's be honest, it has not necessarily been a strength of the NHS that leaders get together at a local level and agree how they're going to do things in a generous, collaborative way based on the needs of the patient. I mean, I wish it was the case that it was always like that, but we all know that it isn't always like that. If it is important to the plan that we do develop a consensus locally about how to organise things, how can we get better at that than we have been in the past?
So, if I may, Matthew, just going back just really briefly to the last point, because I don't think IHOs and ICBs, it's one or the other. IHOs will still need commissioning against the total population budget, and ICBs will have a role there. So I know the detail of this will become clearer as the new legislation gets drafted and we work through the practicalities of this. But I don't think it's either or. I think it's a case that an IHO would have greater capabilities against a total population budget in order to deliver the outcomes that the ICB commissions from them. So I don't think it's an either or. Just this point about leaders and convening and how we build trust. So there's huge opportunities in the plan. There's lots of things that need to be addressed, whether it's the structural stuff, the funding flows, the infrastructure. One of the most fundamental things that doesn't get mentioned at all in the plan, but will require a great deal of thought in terms of how we approach it, is how we continue to build trust and relationships. And actually, we've done a lot on that over recent years. The slight danger is, as we move to a more competitive landscape, that becomes slightly more challenging. So I think it's important that all leaders have this overarching duty to the NHS and the outcomes, and not simply to the sovereignty of their organisations or their IHOs. And I would like to see a conversation that's far more explicit about that in terms of the expectations on all leaders.
I absolutely agree. And Claire, straight to you on that question, I often share with people the fact that someone I know well has done a lot of work with health service leaders and speaks about them with admiration. But there's a but. And when I say, what is the but? This person says, NHS leaders are quicker than leaders in most other sectors that I've dealt with, she says, to blame other people. There is a kind of willingness to say, well, of course we would be able to do that, but the acute is impossible. We'd be able to do that. The GPs won't work with us. We're able to do that, or the local authority. How do we get out of that mentality of reaching toward blame when we can't get our act together at a local level?
Yes, but we used to call it othering. When I was back in my old job in Surrey, and it was one of those, you're not allowed to ever say anything, was somebody others, somebody others. Because it's always the person that wasn't in the room as well, isn't it? It was always the person that stops you doing it. And the way you reframe it is you just come back to, this is about patient care and it's our responsibility to the population. And Sam spoke very clearly about the need for leadership. My real priority is around the clinical leadership. So this change, particularly the neighbourhood health working, because it will involve how we do UEC different, how we'll do elective differently, let alone how we'll do prevention differently. But actually, that's a significant change in clinical practice. And this fundamentally will be about doctors working in different ways and leading teams in different ways, and other health professionals as well coming together to make sure we get that right skill mix. So one of the bits that I've talked about a lot over the last year or so really has been this primary secondary care divide. And unless we break that down, and the only way you break it down is by getting local leaders in a room together and actually going through all those grunty, really irritating bits that just kind of get in the way. It's the back to the basics bit that comes through in the plan. We can't go off and do all the fancy stuff, but actually you're still really irritated because I'm dealing with 28 different forms and it keeps getting rejected, or because nobody ever answers the phone in the pediatric secretary, nobody can ever get you. So you've got to put in place those really local forums to deal with the basics. You've got to get your clinicians in a room together and be really clear what it is you are trying to fix. One of my colleagues, James Kent, who always talks about we have the James Kent scale of collaboration, and level 1 is that you're meant to collaborate. Number 2, level 2 is that who you meant to collaborate with. Number 3, and it goes up. And actually, most people are probably, they know who they're meant to collaborate with, they know it's a good idea, and they've been in a room and they've got their, and they now talk to each other. But actually, it's not until you get on, you actually deliver services together that you change this and you do this. So the quicker people at a local level build those relationships, get in rooms, but also identify from looking at the data of the local population, what is the greatest need, and fix it. That's how you unlock it.
Yeah, in our work on that kind of interface, we sometimes talk about the 3 steps, which is irritation, integration, and innovation. First of all, you've got to stop pissing each other
Yeah, it's
off.
good. Yeah.
Then you've got to start working together, and then new ideas will start to emerge as a consequence of that. But you have to go through those stages. No good trying to innovate when you're still annoying each other.
Exactly.
Sam and Claire put this emphasis on relationships and trust and all of that, but incentives also matter, Bill. How convinced are you by what the 10-year plan has said? And clearly some of this stuff is now a bit more tentative, a bit more experimental than in earlier iterations. How convinced are you of the 10-year plan's attempt to shift the incentives in order to particularly to drive the leftward shift?
Yeah, I think I'd say relatively convinced. I think the foundation of financial incentives is financial stability in the system. And I think everything in the plan, and actually since Jim became chief exec, about how, transparency of financial flows and a rules-based system. And that is a very coherent theme coming out in the 10-year plan as well. And that it's so important to get to this system quite quickly if we're then going to create a world of financial incentives to move care around. Because financial incentives simply don't work if everyone's in deficit. And there's extraordinary bungs flying around the system. It kills everything. It won't surprise you to know I'm a fan of financial incentives. This is a similar theme to the original Lansley vision as well, but it does need that foundation of financial stability to work.
And Sam, the leftward shift, we've been talking about it for decades and we actually achieved a rightward shift. I'm sure you would agree with Bill that it's very hard to do when people are in deficit. It's also hard to do when a system is at full capacity. What do you think is the key to unlocking this? Because the credibility of the plan relies upon the leftward shift starting to deliver a shift in productivity pretty quickly. Now, there is evidence that if you do things in primary and community, you will save money, but the plan doesn't really work if we don't do that quickly and we don't reap those rewards pretty quickly.
Yeah, and look, we've all got a role in this. So I think the incentives are actually key here. So whether it's changing the financial flows around the urgent and emergency care pathway, which doesn't just reward attendances in the ED department, but also rewards preventative attendances in the ED department in the right part of the system is going to be key. I think for us as commissioners, setting ourselves realistic but ambitious goals of left shift in terms of where we place our resources, and being really clear with parts of our system that actually they are going to have to address the reasons why perhaps aspects of their services cost more than others. They are going to have to address the productivity and not accept a mediocrity, and ensuring that we're using the data to drive the best possible outcomes for our patients and get the best value for the taxpayer. And I think this is a real wake-up moment for everybody, actually. So I think every part of the system needs to be examining what their role is in making that left shift, and we've all got a role to play, Matthew.
Claire, part of the achievement of the left shift is the willingness of primary to take on risk to a certain extent, to kind of say, well, look, our funding is going to depend on us demonstrating we can reduce unnecessary A&E attendances, that we can reduce, there's a bold commitment to reduce acute outpatient activity, for example. How ready is primary to take that kind of risk on?
So if you put it back into a clinical bit, primary care holds more risk from a clinical point of view than any other part of the system, and we're really used to handling risk and looking after people in really difficult situations. There is a very difference in the way the funding floats for particularly partners in general practice, that actually it's your livelihood, isn't it, that makes it very different, which is why it's this move into neighbourhood providers and multi-neighbourhood providers and working in partnership with larger organisations, I think will help general practice and primary care more broadly move into a position to be able to share risk with bigger organisations. I think Sam's right again. The unblocking of the UEC tariff will be the bit that starts this and the move to the year of care payments. But I think that of course, there's an appetite to do things differently. In general practice, if you make it really clear where the financial incentives are and the ability to reinvest savings to improve local patient care, then people will be willing to step up and do that. But it's got to be with the right protections of people's livelihoods.
Last question for you, Bill, and then I'm going to ask you all one closing question, but specifically for you, Bill. This, of course, is a tech-tastic plan. some really big ambitions in that regard. And there's a certain irony, isn't there, that the plan on quite a few occasions talks about ambient voice technology as being an example of a kind of breakthrough technology that's going to change things. And this comes a few days after a long letter from NHS England saying to people that you mustn't carry on using the AI systems you're using because they don't meet information governance standards. What tip would you give to Wes, to Jim, to leaders about how we get this technology stuff right? Because we really, really haven't in the past.
Yeah, we haven't. I think the NHS app bit of the plan was great, politically, by the way. We're going to have my GP, my consultant, I was like, if, you give that to MPs, they'll absolutely love it. And you're right, though, in terms of how on earth you deliver this, that's extremely difficult. And I mean, we've been trying to get the app to dock into Trust's e-booking systems for literally years. And it's still, you can view appointments on the app, but you can't change them even now. So it's, it's a long old slog to get there by 2028. I think in terms of the adoption of tech, where we get it wrong is it's got its foundations in the capital regime. Like, what you need to do is design a capital regime where it makes sense for a frontline provider to adopt tech and use it effectively and invest in tech. But because the capital regime doesn't work especially well for tech, what we end up doing is procuring tech nationally. We get a good price for it, but we procure it nationally and then tell frontline organizations to use it. And they don't own the adoption of it. And I think that's a challenge which, we have to overcome if we're going to really harness the benefits of all this fabulous AI and other tech which is coming.
Yeah, I think that there's an implicit idea that I know some people argued for around the plan and doesn't quite make it in explicitly, but that's a kind of recognition that we will have a twin track health service. There will be a national digital offer, which is commissioned nationally and provided nationally and is universal in the same way as, online banking might be. And then there is local services and the way that local services use technology. And I think it'll be interesting to see how that evolves. So look, here's a kind of final question for you all, and it's a reflection of my own failure and inadequacy, because I had an argument with the 10-year plan team and a bit with Wes about something I wanted them to say more explicitly in the plan and wish they didn't. And indeed, I spoke to Wes about this the other day, and at last plea, I said, look, as you launch it, could you say this? And what I wanted him to say was how important patients and the public will be to the delivery of this plan, that patient attitudes, patient behaviors, patient expectations, the willingness of patients to do things differently are really critical. The story here, I think, is at the beginning of the 10-year plan process, they did some focus groups in which they said to people, do you think part of this is about you taking on more responsibility? And the people out and said, no, sod off, it's about you providing better services. I kind of get that, but I still think we ought to be engaging in all sorts of ways, from, the public being willing to support difficult reconfiguration to using the app, whatever it might be. When I spoke to Wes about this the other day, he said, look, Matthew, if you want to make unpopular arguments to the public, you go for it, mate. So we will carry on saying that. Sam, how important do you think it is, without, of course, wanting to contradict our Secretary of State, that we have a message here to the public about their importance in achieving the transformation we want to achieve over the next few years?
I think it's really crucial, Matthew. I also have empathy, I guess, for the Secretary of State, that perhaps saying that sort of thing nationally may run the risk of being viewed as the nanny state. And actually, one of the really exciting things about this plan is the devolution, the local decision-making. So in part, I see that as our responsibility at a local level. We know our populations, we can work with our voluntary sector organisations, all of our community partners, local politicians, to be able to have that conversation, which is actually, when we're looking at services and the shape of services in the future, this is what the evidence tells us. Actually, how can we co-produce aspects of this with our population, but also how do we have a conversation with them about what is all of our role in safeguarding an NHS free at the point of delivery for the future? And I think some of the announcements last week around Health Watch, and I mean, we've got brilliant relationships with Health Watch locally. They are really valued. But actually, if we're thinking about the future, we'll have some time now to work with them to think about how do we get a more representative voice. And we're starting to think about citizens' assemblies. We need to have a different transparent conversation with the public about the opportunities, the challenges, the choices that we need to make. I'm really conscious that every year as a council taxpayer, I get a bill that arrives on my doormat that tells me what the charges are, what they're for, if I've got a preset for social care. I think we need something similar on health, Matthew. We're spending in our system £1 billion a year at the moment on medication. We've got huge wastage in medication. That's just one of many examples of how the public can work with us to better use the scarce resource that we've got to make the shifts that we need in this plan. So we have to have that conversation, but I think we do that locally.
Yeah, and there's an intriguing paragraph in the plan. Of course, that we're going to have mayors on ICBs as a kind of quid pro quo for the abolition of ICPs. There's an intriguing paragraph that says we might, in the future, explore democratic accountability for ICBs. So that's be interesting to see how that develops as an argument.
And I have no issue with that, Matthew. Our two elected mayors chair a cabinet. They've got programmes of work across skills development, transport. Why not have one on health? And particularly when we know that health, the impacts around transport, employment, these things are all interrelated. So I think the prospect of that actually is quite exciting.
Yeah, no, I think it is fascinating that you take certain elements of the plan to their conclusion. You could see local government ultimately taking on the role of commissioning, and that's a fascinating thing. Claire, one of the things I talk about a lot is that we always talk about access to the health service, but a lot of the time we're over-treating and mistreating people. That statistic that between a third and a half of people with long-term conditions aren't adhering to their treatment. That's not their fault, but it suggests that we're not quite getting the relationship right. That relationship is at the heart of general practice. Do you think we need to be a bit more explicit about needing a different kind of relationship with the public?
So I think this is it's complex, isn't it? So I completely understand why you're saying what you are, but I always worry about the most vulnerable. Because you go back sort of in COVID when we say, we're really busy, we're overwhelmed, don't come, and people stopped coming in to see us. So I think this is about really local conversations that are tailored to your local community to make sure that we don't exclude our most vulnerable. So particularly around things like, you've got to do everything on the app. Not everybody has got a smartphone, and my parents, my dad is really tech savvy within IT before, back in the 60s and things. He'll use his big computer, but he won't do it on his phone because he can't see it very clearly and can't necessarily access really. So it's making sure that locally, for those people that do still want to access in different ways, that we make sure that services are available for them. I was in Frome recently, and they have, while people are waiting, somebody that comes in, a digital champion that makes sure it helps people load it onto their phone and make sure that they can gain access. So I do think there's local nuancing to the conversation, and I think it's on us as leaders to make sure that the service is as accessible as possible and works in a way that works for the population. So it's always both, Matthew, isn't it? It's always both. But around the long-term conditions bit, we need to make it easier for people. And for most people with one or two long-term conditions, they're fit and well and healthy. And actually so in North Central London, they've been working with UCLP and actually been looking at how remotely you can improve your monitoring of long-term conditions. So, if any of us had hypertension, we might want to check our own blood pressure, book in for a blood test to get stuff checked. And actually you might never need to see a GP, or if everything is well and it's tugging over. So we just need to make it easier for people to manage healthcare in the way that works for them and keep them safe at the same time. But it isn't going to necessarily be book an appointment to see a GP once a year for every single different condition that you might have.
So thanks, Cliff. Final word with you on this, Bill, looking at this through a political lens, what commercial organisations can achieve is that they can make decisions without the burdens of public accountability. A bank can say, look, we're going to close our branches and you'll have to go online, and it's a bit controversial, but it's not career threatening in the way that a similar decision to close a hospital might be for a politician. How should politicians be talking to the public about this? It feels to me like ever since the failure of the big society from David Cameron, there's always been a nervousness about being explicit with the public about how they are part of the solution. But do you think the politicians should be articulating that more?
I think it's always tricky to get ministers to tell the public difficult things. You might wish it otherwise, but it's
You'd
quite
be one
tricky.
of the people saying to Wes, you should ignore that Matthew Taylor.
Well, it does lead you to certain things. So you may as well do the difficult things now, so because we're quite a way away from the election still. So, if you're going to crack through an FT pipeline, then start now, with the really tricky ones, and then calm it all down ahead of the next election. What can really help politicians do difficult things in the NHS is clinical leadership. And I think the stuff in the plan, as Claire mentioned earlier, about the modern service frameworks and the reinvigoration of the National Quality Board, this to me creates scope for clinical leaders to make difficult arguments. And it reminds me of, Mike Richards tackling the number of prostatectomies in the 2000s. Really difficult message about how the services needed to close, and he led it very well. So I think those are the kinds of arguments that need to be made by clinicians.
Yeah, well,
and hopefully not be undermined by politicians in the process.
Well, I can see Sam and Claire both nodding their heads at that. So maybe you're right. Maybe it's not the message that's the issue. It's the messenger, and we ought to be using clinicians. Bill, Claire, Sam, thank you so much for joining us this morning. It's been an exciting week for the health service. The sun is shining. Have a lovely weekend.
Thank you.
Thanks, Matthew.
Well, thanks ever so much to my guests, Claire, Sam, and Bill, for sharing their thoughts with you today. As I say, keep an eye on our website. We're going to be posting lots of opportunities for members to get involved in discussions around how we work to make this plan a reality, because in the end, it is all about implementation. But that just leaves me to introduce our Leader in 6 interviewee, and that's Gabby Aida, Chief Executive of Evelina London Women's and Children's Services, part of Guy's and St Thomas's NHS Foundation Trust. I strolled across the river last week to meet Gabby and members of her team. It was absolutely fascinating.
So here are your questions. First one, what's the biggest challenge you're facing at the moment, Gabby?
Right. So I've been here about 2 years now, although I feel I've been here forever. I think I heard this phrase, ambidextrous leadership.
Right.
And it so resonated with me. It's about BAU and strategic. We have quite a lot of strategic projects, that are consuming all my executive team. And then we've got all the BAU, the delivery, the quality, the waiting lists, financial sustainability, everything we're supposed to be doing on the tin to keep the hospital going. But we also have to do the strategic, the future here and now. So when my team say, well, what do you want us to do? This or that? Both. And we are learning. How do we do that? How do we delegate? How do we have people working at the top of their license? What is it only we can do? What is it that they can do? We're stretching our next layer down because you've got to take care of business. And we know what the pressure of that is. But then we've got to say our job is to, if we don't start 5 years now, when we get there, and it's that, ambidextrous.
Well, I certainly recognize that as a leader. I'm sure other people will as well. Tell me about a single improvement or innovation in your organization that you're particularly excited by or proud of.
I think there are quite a few, but I think the one that leaps out for me is how we're combining women's and children's being part of the clinical group and leveraging that. So it's all about that whole life course approach. And one of the things that we've got now is that in Lambeth and Southwark, which is our place, we have data on every baby born here. And we've got the opportunity to follow them through and really have data on them all the way through to adulthood. That is a game changer, I think, for us. So the opportunities that will come out of that, the way we'll use that data to influence and target, especially with the whole inequalities thing. So I'm very excited about that. And of course, we've just moved to Epic. So it's the ability for Epic as our electronic patient record to link with primary care. That's the challenge in itself. But if we can actually do that, then we can actually start creating healthcare by need, not just talking about it, but really doing it. So I'm quite excited about that aspect.
Yeah, great. Of course, your new boss in a couple of months is going to be Amanda Pritchard, who did run the health service, which links to my next question, which is, if you were queen of the health service for a day, what's the one thing you did?
If I was queen for a day, I would ensure that there is sufficient allocation for leadership and leadership training. I cannot tell you, because that's what's going to really make the difference. And in fact, I sort of think paradoxically, you almost want to put your crack team in the most challenged areas, because if anybody can do it, they can, rather than moving them to the ivory towers where it's great and you're in a place where you're being inspired. But if we're looking at healthcare as a whole, the continuum, and it's not about geographical location, leadership is what is going to be able to transform the way we work. And I don't think we do enough of that.
I completely agree with you. And we do quite a lot of leadership development at the convent. And I think, people see it as money being spent on bureaucracy, but it's not. It's absolutely critical. So I completely agree with you on that. Which takes me to my next question, which is, tell me about a leader you particularly admire. It might be someone you've worked with. It might be, someone globally, but just a leader that's inspired you.
I'll come closer to home, and I'd probably actually say Leslie Watts, who was
Chelsea and Westminster.
Yeah, Chelsea and Westminster, which is where I was a divisional medical director, and then she moved me across to be an interim because in another trust that she was sort of overseeing. And Leslie, for me, I don't know how she found time in the day to do walkabouts and do everything else she was doing, not just for the hospital, but for the region and then nationally. And it's how to lead and then still have that pop-up on a ward. I want to aspire to do that, because in my head, I want to be a visible leader and compassionate. But in my day, I can't, because if I get to the ward, I can't get back in time for a meeting. So I loved that about her. And I loved the fact that she is so plain speaking. She calls it as it is. If you say you can do something, she goes, you want to do it? Do it, but don't come back. And so the challenge is then on you to do it. So I think there are lots of global, but always for me, it's related to where you are now.
Gabby, you obviously work incredibly hard here, doing your ambidextrous leadership as best you can. But tell us something about yourself that's nothing to do with your job.
Oh, gosh. For us as leaders, you have this double life. And it's almost I'm immediately uncomfortable. It's like, oh no, this is the face I bring into the NHS. I've got an amazing Akita, dog.
Oh, right.
Big, elegant dog. And so I would say
Dog walking is good for the
dog walking is good for the soul. It's where I get my best thoughts. It's either I dream them or when I'm going on a walk. So that for me is very therapeutic. Even holidays now, because life is so busy, I can't do anything when I'm not working. For me, the luxury is time that's my own. I wish I could say I've got these amazing hobbies. I go to the theatre, but actually what I crave now is just like silence and my own companionship.
And final question, share with us something that you've read, something that you've watched. It could be anything. Someone had someone said White Lotus, someone said something. Anything you've watched, read, listened to that you've enjoyed and you recommend to other people.
So, in fact, this is very recent. I watched a private screening of a short film called 22+1. And it was a dramatization of a Black pregnant woman married to a white guy. And it was really her experience through her pregnancy. It is the most powerful film I've ever seen. And how I actually got to be at the first screening was a story that happened to one of my previous patients who wrote a book, and I helped her with the medical accuracy of it. But she was white. And she's in the media, and she's a journalist, and she started researching this and then saw how her story was superimposed in a Black woman. So she got an actress to do that. They collaborated. This film was so powerful that I thought everybody in my about all the inequalities. Everybody in my maternity unit needs to see this film. So well done. And myself and the director of midwifery, we're going to bring the film to our maternity service. And then I thought, no, actually, I'm going to show this to everybody involved with maternity. So the national chief midwife, the chief nurse, the clinical director nationally, regionally, chief nurse regionally, clinical directors. So we got CEO of our ICB. So we gathered all of these people last night for the first NHS private screening. And you know how that moment, about 5 minutes before it starts, and you go, what if they just have the same reaction as I did? And honestly, the reaction and the conversation we had afterwards was probably one of the richest, because if we had to have a hashtag, it was, instead of awareness and knowledge and data, is to convert it into action and move the dial on Black maternal inequalities, but beautifully done, thought-provoking, and literally just so much authenticity in the room. And I couldn't have timed it better because, of course, this is the week that West Streeting has just had announcement and has called out inequalities from a race point in maternity. So for me,
Brilliant. And do you know when the rest of us will be able to see this?
very soon, because I have challenged our leaders, our decision makers, our influencers there, that if you feel like me, which they've all said, then this is what everybody has.
So we'll look out for it on general release.
There you go.
Gabby, thank you so much.
My pleasure. My pleasure.
Thank you.
You've been listening to Health on the Line, produced by Health Comms Plus. Health Comms Plus is a highly effective, innovative and creative communications agency brought to you by the NHS Confederation. We offer a creative, professional and cost-effective service for NHS and public sector organisations across the UK. Any profit we make is reinvested in the support we provide to NHS organisations and wider health and care systems.